Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will speak about a new subject on pediatric surgery made easy. Our subject today is very important, related to gastrointestinal tract duplication, which means that the gastrointestinal tract or some part of it is doubled. We may have two parts of the esophagus, stomach, small bowel, or large bowel. It's very important malformation for all pediatric surgeon and pediatrician. The problem may present with acute or chronic symptoms, or may be discovered incidentally. So the pediatric surgeon should be aware of it and its variety. Let's start. Alimentary tract duplication or gastrointestinal tract duplication. Very important item. At the end of this presentation, you should be able to know embryology of the gastrointestinal tract, the clinical presentation and the diagnosis of the gastrointestinal tract duplication, the treatment, and also the classification of the disease as regarding the anatomical region. Esophageal, thoracoabdominal, small bowel, and colonic rectal duplication. At first, the first question is, what does the gastrointestinal duplication mean? It's a rare congenital anomaly. Means that there is a spherical or tubular structure present anywhere from the in the gastrointestinal tract, from the mouth to the anus. So we may have a duplicated part in the gastrointestinal tract. Double part like this, pouch, small pouch, may be spherical or may be tubular, may be related to the esophagus, to the stomach, or the small or large bowel. The disease previously described as enteric cyst or giant diverticula, or sometimes unusual Meckel diverticula. So this is the previous names for the disease or for the disorders. However, the term alimentary tract duplication was introduced by Ladd in 1937, and Ladd requested three criteria for the diagnosis of alimentary tract duplication. To consider this as alimentary tract duplication, Ladd requests three criteria. Number one, the duplicated part is intimately attached to the part of the gastrointestinal tract. So this is the esophagus and the duplication is closely or intimately attached to it. Number two, the duplicated part contains a well-developed smooth muscle coat. Number three, the epithelial lining of the duplicated part is constant or the same as that of the gastrointestinal tract. So to consider this malformation as alimentary tract duplication, we need intimate attachment to the part of the gastrointestinal tract, well-developed smooth muscle coat, and epithelial lining the same or constant as that for the gastrointestinal tract. The second question is, what is the incidence of this gastrointestinal tract duplication? It's relatively rare congenital malformation, found anywhere from the mouth to the anus, reported to be about 1 in 4,500 births. There is an overall equal sex distribution between male and female, and there is a small percent of cases present in the neonatal period. However, more than 80% of the cases present before the age of 2. So, what is the classification or the types of gastrointestinal tract duplication? Embryologically and for treatment purpose, the gastrointestinal tract duplication could be classified according to the parts of the gastrointestinal tract. We have a foregut duplication related to the foregut part of the primitive gut, and then mid-gut duplication related to the structure derived from the mid-gut part of the primitive gut, and finally hind-gut duplication. So the extension will be the foregut duplication will include some part of the respiratory tract, the esophagus, stomach, first portion, and proximal half of the second portion of the duodenum, and end in this point. Then mid-gut duplication start with the distal half of the second part of the duodenum, jejunum, ileum, cecum, and appendix. Ascending colon, proximal 2/3 of the transverse colon is included in the mid-gut duplication. And finally, hind-gut duplication includes the distal third of the transverse colon, the descending and sigmoid colon, the rectum and the anus, some component of the urological system. So this classification is important for the diagnosis of the affected part and also related to the presentation and to the treatment. Most gastrointestinal tract or alimentary tract duplication are cystic, and some are tubular, tube-like. Ileum and jejunum are the most affected parts, followed by the esophagus, the epithelial lining, as we says, usually native to the surrounding gastrointestinal tract. However, ectopic mucosa is found in about 1/3 of the duplication. It's very important that this ectopic mucosa may secrete HCl, may contain acid-producing mucosa, and may lead to hemorrhage or gastrointestinal bleeding. So the most common ectopic mucosa is the gastric tissue. This is the most common, followed by the pancreatic, and there are some reports of respiratory epithelium in this ectopic mucosa present in the duplicated part. So the duplication may form some disturbance or may present with acute hemorrhage, bleeding gastrointestinal tract, which is an emergency, late diagnosis and treatment by the pediatric surgeon. Now, one should ask, what is the etiology? Why this malformation happened? Surprisingly, the pathology for the development of the gastrointestinal tract duplication is unknown, and multifactorial process is suggested, trying to explain the etiology. The multifactorial process suggested due to associated malformation of the vertebral and spinal cord, genitourinary tract, sometimes intestinal malformation, malrotation, and atresia. So duplicated part of the bowel may present associated with vertebral or spinal cord anomaly, sometimes called the enterocystic disorder. There is a cyst related to the enteric system and the gastrointestinal system. May be related to genitourinary tract anomalies associated with this duplication, and also intestinal malrotation and atresia may be associated with the duplication. Pediatric surgeon should be aware of this association to search for the presence or absence of associated anomalies in about 20% of cases of the duplication. There are 5 theories trying to explain development of gastrointestinal duplication can be summarized as follows. Number one, partial twinning, split notochord, diverticular defects, canalization defects, and environmental factors, trying to explain why this duplication, or previously called diverticulum, happen or occur. Partial twinning theory proposes that the tubular gastrointestinal duplication may be secondary to or a form of partial or incomplete or absorptive twinning, may be relevant in the hind-gut duplication associated with genitourinary anomalies. Also may be associated with the spine and central nervous system anomalies. So this is the first theory trying to explain the etiology or the pathogenesis for the gastrointestinal tract duplication. Number two is a split notochord theory, focus on the notochord separation in the first months of gestation. The theory supposes that there is a gap in the notochord develop and allow the gut endoderm to herniate and form diverticula. It could account for the association of the duplication with a spinal defect, as notochord is a solid cord present in the embryonic plate, simply related to the formation of the enteric or nervous system. So there is maybe a splitting in this notochord. There is maybe communication between the gut endoderm and herniation and formations of the diverticula. This is one theory trying to explain this gastrointestinal tract duplication. Persistent embryonic diverticula from the gastrointestinal tract. This is the first theory described, and based on the identification of the numerous diverticula in the intestinal tract of the embryo, and led to the proposal of the extension of these diverticula into duplication. So they propose that there is multiple diverticula in the intestine of the embryo. These diverticula may persist and form gastrointestinal tract duplication. The frequent ileal position of these diverticula is consistent with frequent ileal location of the gastrointestinal duplication. So there is relations between the presence of the diverticula in the intestine of the embryo in the ileal part, and also the frequent presence of the gastrointestinal tract duplication related to the ileum. Maybe defective canalization is the etiology, based on the finding that the gastrointestinal organs began as a solid tubes and then vacuolate and form the lumen. During this process, diverticula form but regress during the fetal life. If they persist, duplication could form. So this theory supposes that during the solid stage and the transformation into the luminal stage, there is a diverticula, and these diverticula persist and don't disappear and present later with gastrointestinal tract duplication. Environmental factors may be involved in the development of the gastrointestinal duplication, including some form of hypoxia, vascular accident, and trauma. Intrauterine vascular accident is a known precipitators of the other congenital anomalies like gastrointestinal tract atresia, so they may be also related to the formation of gastrointestinal tract duplication. So it is a multifactorial process. No single theory could explain the formation or the development of gastrointestinal tract duplication. However, there is maybe partial twinning, there is maybe split notochord, there is maybe persistent diverticulum, there is maybe canalization defect, there is maybe environmental factors. All these theories may play role in the formation of gastrointestinal tract duplication. Maybe single theory, maybe in association with each others. Now, what is the clinical presentation of the gastrointestinal tract duplication? It's very important to understand that the presentation is highly variable, ranging from acute or chronic symptoms or maybe asymptomatic and diagnosed incidentally. So the presentation may have two ends. Acute or chronic presentation may be asymptomatic and diagnosed incidentally. The symptoms of the gastrointestinal tract duplication usually related to the size of the duplication, larger duplication or a smaller one, the location in the foregut, midgut, hindgut, and the presence of the ectopic mucosa. It's seriously important that this acid-producing mucosa may present with gastrointestinal bleeding or hemorrhage. So these three items will affect the presentation of gastrointestinal tract duplication. Gastrointestinal duplication can present with abdominal pain or distension or present as a painless mass. Also, duplication may present with intussusception, as a duplication can act as a lead point for the intussusception to start. Or duplication may present with localized volvulus of the small bowel. Sometimes painless gastrointestinal bleeding or perforation by the ectopic acid-producing gastric mucosa can cause peptic ulcer of the normal intestinal mucosa. May be serious presentation, and pediatric surgeon should be aware of this. Pressure necrosis from the adjacent duplication also can lead to hemorrhage or perforation. Sometimes obstruction involving the esophagus or the small bowel due to the mass effect located on the mesenteric surface, or sometimes respiratory compromise due to tracheal obstruction with a foregut duplication cyst. So the presentation is wide. Sometimes some cases not diagnosed except enteral. It's very important to put in the differential diagnosis. Child, neonate, present with gastrointestinal bleeding, present with respiratory compromise, present with obstructive symptoms. It should be put in the differential diagnosis. The associated anomalies is very important in about 20%, with the most common malrotation, intestinal atresia, spinal anomalies, and the genitourinary anomalies. So the pediatric surgeon should search for associated anomalies. Sometimes this duplicated part of the bowel is connected to the spinal canal, is connected to the vertebral body. Maybe enteric disease or enteric cyst related to this part. Communication between the bowel, the small bowel, and the spinal cord or spinal canal. It's very important association and serious one. And in that condition, a neurosurgeon may be involved during the surgery for correction of this gastrointestinal tract duplication. How to diagnose gastrointestinal tract duplication? With the advancement in the prenatal imaging, many of these diseases or masses are being diagnosed in utero, which is very important. Majority are diagnosed before the 2 years of age, not diagnosed prenatally. Recent study found that about 58% of the duplication were diagnosed prenatal over a 25-year period of work. So it's very important that the advancement in the technology of the prenatal ultrasound will be very helpful for diagnosis of this disorder. Prenatal ultrasound, its use increase significantly with the development of the higher resolution scan, also can be followed by the postnatal ultrasound, which may be sufficient, especially for the distal small bowel lesion. Two sonographic signs are highly suggestive of the gastrointestinal duplication. Number one, the double wall sign. Number two, the presence of peristalsis. With these features, the diagnosis described as early as 12 weeks of gestation. So it's very important. The antenatal care is very important for this diagnosis of this congenital malformation. The double wall sign means that there is a cystic lesions with an outer hyperechoic rim of the serosa and inner, this is the dotted arrow, inner hyperechoic rim of the mucosa and submucosa with hypoechoic muscular layer sandwiched between the two hyperechoic layers. So we have outer hyperechoic rim of the serosa, inner hyperechoic rim of the mucosa and the submucosa, and hypoechoic muscular layer in between. So if the cystic lesion shows these criteria, sonographic criteria, this is called the double wall sign diagnostic of gastrointestinal tract duplication. Two hyperechoic with one hypoechoic muscular layer in between. The plain radiograph may show mediastinal mass, which require further workup with the CT or MRI. The CT or MRI may prove valuable, especially for the foregut lesions and especially in operative planning. Presence of the vertebral anomalies, very important, and the duplication is best investigated with MRI to evaluate the communication with the spinal canal, and in this situation, a neurosurgeon should attend the procedure. It's very important to perform CT or MRI to exclude vertebral anomalies associated with duplication and the communication also with the spinal canal. The contrast studies may show the mass effect or the communication with the gastrointestinal tract and can help with the diagnosis, particularly in hindgut and foregut lesions. Scintigraphy may be used as adjuvant imaging, but it's likely unnecessary in most cases. The question now is how to treat. So we know the presentation is very wide presentation, also the diagnosis and the advancement in ultrasound scanning. How to treat? Generally, gastrointestinal duplication best discussed according to the anatomical regions: foregut, midgut, and hindgut. It's very important to discuss according to these anatomical regions. The goal of the operative treatment is to remove the duplication, to eliminate or remove the patient's symptoms and prevent recurrence. However, surgical procedure should not be more radical than necessary to avoid complications. So pediatric surgeon need to remove the duplicated to relieve the symptoms, prevent recurrence. However, keeping the performance of the gastrointestinal tract, not leaving the baby with a short bowel, not leaving the baby with other disability, taking in consideration the associated anomalies, the association with the vertebral canal or spinal cord, very serious. So your aim as a pediatric surgeon is to remove these duplicated part, to treat the symptoms if they contain ectopic mucosa secreting acid producing bleeding, and also to prevent the recurrence. Timing of surgery. Very important. Almost half of the infant diagnosed prenatal, as we said, become symptomatic early in life, and these infants need resection. However, in asymptomatic patients, some pediatric surgeons suggest consideration of close observation and delayed prophylactic resection in infancy. So, about half of the infant will diagnosed very early and become symptomatic very early. This half will be subjected to surgery. However, in asymptomatic patient, some pediatric surgeons consider close observation and delayed primary resection in infancy. The surgical option in general, and we will speak about it in details related to each part. Simple cyst resection, this is one option, but because most share a common blood supply to the native gastrointestinal tract, the resection with primary anastomosis is often needed and curative depending on the location. So if it is feasible to perform simple cyst resection, it's well and good. However, usually these duplicated parts share common or same blood supply. So you may need to remove part of the normal gastrointestinal tract with the duplication cyst and perform primary anastomosis. Maybe bowel resection, yes, and this is required in about 34% of cases. In a long tubular thoracoabdominal gastroduodenal duplication, may present more difficulty challenge, as resection may carry significant morbidity, may lead to short bowel syndrome, and we will speak about some solution for this problem later. So if you decide to remove or resect the bowel with the duplication, you may face with a short bowel syndrome. Partial excision and mucosal stripping, removal of the mucosa that contain the ectopic mucosa. So maybe the best option in certain conditions. Overall prognosis is favorable, but associated malformation, location, presenting illness can affect the final outcome. So to strip out the mucosa and do partial excision of the duplicated part. Why we remove the mucosa? Because this mucosa may contain the ectopic or heterotrophic gastric tissue producing bleeding. Also, there is some reports speak about the development of malignancy in these duplicated parts. We will speak about regions and classify the duplication by region. The first part is the esophageal duplication. Duplicated cyst, whether cystic or tubular, related to the esophagus. About 16% of the duplications, the cervical or abdominal esophagus could occur. However, the majority located along the thoracic esophagus and in the right chest. Most esophageal duplications are cystic and share a muscular wall with the esophagus, but don't communicate with the lumen. This is a duplicated part. This is the native esophagus. So this red line represents the cleavage plane between them. So most share a common muscular wall, but don't communicate with the lumen. Esophageal duplication can also have a respiratory epithelium, primitive lung related to the duplicated part, and should be included in the differential diagnosis of any patient with posterior mediastinal mass. Patients often present late in the esophageal duplication, as they cause relatively few symptoms, not communicate with the lumen. However, cervical esophageal duplication can cause significant respiratory distress, requiring airway control and surgery. So the esophagus duplicated part may be very large, may cause compromising of the lung function, severe respiratory distress, and need urgent surgery. So may be asymptomatic or may present with significant respiratory distress. The clinical presentation, despite the wide range, esophageal duplications are commonly asymptomatic, diagnosed incidentally, either prenatal, as we said, or during the workup for unrelated problem, as a respiratory infection, recurrent respiratory infection, or trauma. So esophageal duplication may be cervical or abdominal, may be related to compromise of the respiratory functions, or may be asymptomatic, may present with recurrent infection. The clinical presentation will depend on the mass effect, the size, and the presence of ectopic gastric mucosa. Esophageal compression may present with dysphagia or regurgitation. Lung compression can present with recurrent cough or pneumonia. Peptic ulcer leading to anemia, hematemesis, which is very rare. About 40% of the esophageal duplication contain ectopic gastric mucosa. Very important. This ectopic mucosa is a source of many problems related to ulceration of the surrounding mucosa. Surrounding healthy mucosa will become ulcerated by the effect of the gastric mucosa secreting HCl. Investigation related to the plain radiograph may show an air or fluid field structure in relation to the esophagus, although this is not usually enough to confirm the diagnosis. The contrast studies can provide useful information regarding the size of the lesion and whether the lumen communicate or not. Axial CT or MRI is helpful once a duplication is suspected. As we see, this arrow demonstrate the presence of esophageal duplication cyst. Abdominal ultrasound is very important to evaluate for the present or associated duplication of the abdominal esophagus, as about 25% incidence described. Ultrasound is an effective, inexpensive, and have a little risk. Technetium scan may reveal the presence of the ectopic gastric mucosa in case of gastrointestinal bleeding. So may be used in case of gastrointestinal bleeding to confirm the presence of ectopic mucosa. How to treat? Esophageal duplication should be removed. Due to risk of malignancy, may be symptomatic at some point. With increased use of the thoracoscopy, many esophageal duplication being resected with this minimally invasive approach, rather than the traditional thoracotomy. So the duplicated cyst should be removed to avoid malignancy, and considering that this duplicated part may become symptomatic at some point. The surgical excision of the cyst can be performed by the creation of cleavage plane within the muscular wall that is shared with the native esophagus. As with any chest operation, the care should be taken to avoid injury to the adjacent structures, including the phrenic and the vagus nerve. It's very important to take care not to injure these important nerves. If complete excision is not visible, stripping of the mucosa from the cyst wall will allow for the obliteration of the cyst and the resolution of the symptoms. If there is any concern for the esophageal injury post-operative, a post-operative esophagogram should be done to evaluate for any leak, suspected leak. It's very important to know these items very well. Duplication of the esophagus need to be removed. To avoid malignancy, that the patient may become symptomatic, about 40% contain ectopic gastric mucosa. Thoracoabdominal duplication. What is meant by thoracoabdominal? Thoracoabdominal meaning that extension of the esophageal duplication in the abdomen. Duplication affecting the thoracic esophagus with abdominal esophagus. This quite rare, about 2% of the duplication, often lies separate from the esophagus, more often on the right side, may be attached to important structures, as the aorta, azygos vein, tracheobronchial tree. So this is called thoraco. This is the thoracic part. Abdominal part of the esophagus, duplication, extension of the esophageal duplication in the abdomen. They frequently lie in the posterior mediastinum, pass through the diaphragm to communicate with the stomach, duodenum, or small bowel. Like esophageal duplication, also the presentation of the thoraco-abdominal duplication is variable. These duplications commonly tubular, ectopic mucosa found in high percentage, have a high incidence of vertebral anomaly, 88%. So MRI is very essential to evaluate for neuroenteric communication or neuroenteric cyst. It's very essential. Imaging like those for the esophageal duplication with special attention to the imaging of the vertebral column and spinal cord for possible intraspinal component which may need the availability of neurosurgeon. CT or MRI are particularly useful, especially if the neurological symptoms of spinal cord compression or bony spinal abnormalities are present. So CT and MRI is very essential investigation. As we see this myelogram showing defect in the vertebral bodies, and there is filling defect, and these demonstrate communications with cyst in the thorax above the diaphragm and also bowel, small bowel below the diaphragm. So there is vertebral defect, filling defect, and there is a communication between above and below the diaphragm. The current treatment for the thoraco-abdominal, this is the thoracic part and extending into the abdominal part. The current treatment for this long duplication is a one-stage combined thoraco-abdominal approach, maybe thoracotomy and laparotomy incisions, done by open or by minimally invasive thoracoscopic approach, followed by incision in the diaphragm to assess for the abdominal component. It's very serious and very complicated procedure related to thoraco-abdominal duplication. The presence of the gastric mucosa within the thoracic duplication cyst can lead to peptic ulcer, yes, possible erosion into the lung parenchyma presenting with hemoptysis, coughing of blood. This complication may require the surgeon to perform lobectomy. Now we will speak about the second part of the foregut is the gastric duplication related to the stomach. About 9% of the gastrointestinal tract duplication, over 60% of the cases diagnosed during the first year of life, with 40% appearing in the neonatal period by the palpable cystic mass in the upper abdomen, poor feeding due to compression on the stomach of the baby, vomiting, weight loss, and failure to thrive. Most gastric duplication are cystic, not tubular, and arise from the greater curvature and don't communicate with the lumen. In rare cases, they undergo peptic ulcer, and if the cyst communicate with the stomach, hematemesis and melena may be the presenting feature. So the mucosa of the duplicated part may undergo ulcerations with hematemesis if they communicate with lumen or melena. Gastric outlet obstruction, similar to the hypertrophic pyloric stenosis, is a common presentation of this duplication. The gastric duplication occurs twice as often in the female as male, and usually located along the greater curvature. Occasionally they are pedunculated, but most are closed spherical cysts or tubular structures related to the greater curvature of the stomach. The associated anomalies in about 3% of the gastric duplication may be in other cysts, usually in the esophagus, maybe dual duplication of the stomach and pancreas have been reported, thought to arise from error in the rotation of the pancreatic analog. So ventral pancreatic analog rotation abnormalities could result in the double duplication of the stomach and the pancreas. So maybe dual duplication or another cyst in the esophagus and the stomach, or stomach and the pancreas, due to abnormalities related to the rotation of the pancreas. The investigation ultrasound usually diagnoses the duplication. However, pancreatic pseudocyst or choledochal cyst may have similar appearance and be difficult to differentiate with ultrasound. So this is maybe pancreatic pseudocyst, not duplication, maybe choledochal cyst. So CT or MRI help to clarify the anatomy if there is any uncertainty before attempting surgical resection. So if ultrasound is not conclusive, the pediatric surgeon will need to request a CT or MRI to confirm the anatomy and confirm the diagnosis. This is pancreatic pseudocyst, choledochal cyst, or duplication of the stomach. The contrast study may show compression of the stomach, usually along the greater curvature. In a small minority of cases, may demonstrate a communication between the stomach and the duplication. The treatment is primary surgical because of the high incidence of complication, obstruction, bleeding, and peritonitis. So the treatment of the gastric duplication is surgical. The treatment will depend on the location of the cyst and the size of the mass. We may perform wedge excision, as most of the duplication cysts occur in the greater curvature, so the wedge of the stomach is excised with the cyst and the gap closed with single or double layer of horizontal or inverting matrix suture. So we will perform wedge excision, as most cases are cystic related to the greater curvature. We may need to perform partial gastrectomy. Should be avoided if possible in children, and if necessary, only 25 to 30% of the stomach should be resected because of the associated long-term complication. So we need to perform wedge excision or partial gastrectomy. However, try to avoid this procedure if possible. If you decide to perform this, only remove 25% of the stomach. In more difficult locations, as duplication on the lesser curve, the gastroesophageal junction and pylorus, the cyst can be partially excised in a safe manner, followed by mucosal stripping of any remaining mucosa in order to avoid significant gastrectomy. So in this abnormal position, we may perform partial excision and removal of the mucosa. The most important item is the diagnosis. Ultrasound may diagnose or may put the pediatric surgeon in the differential diagnosis. Pancreatic pseudocyst, choledochal cyst, or gastric duplication. Gastric duplication may mimic or similar to hypertrophic pyloric stenosis, vomiting, and mass. So the pediatric surgeon may need to investigate the child with a CT, MRI, clarify the anatomy. The role of the contrast study may be helpful to show compression of the stomach, and if there is a communication, maybe appear. Pyloric duplication, yes. At the end of the stomach, there is a pylorus. So this pylorus may be double. The true pyloric duplication, extremely rare. Very few cases reported. in the English literatures, and most of these presenting within the first week of life. They simulate the symptoms and signs of hypertrophic pyloric stenosis. The main findings are vomiting, weight loss, and palpable abdominal mass. So most cases diagnosed as hypertrophic pyloric obstructions, hypertrophic obstruction. There are certain physical features which are constant with the duplications, the mass usually large and smooth, in contrast to smaller and more mobile olive mass described in the hypertrophic pyloric stenosis. The duplication will be large and smooth mass. Investigation, plain radiograph, signs of the gastric outlet or duodenal obstructions with the lack of the distal bowel gas or rarely calcification within the cyst wall. By ultrasound, inner echogenic mucosal layer and outer hypoechogenic muscular layer differentiating the duplication from mesenteric cyst. So the echogenicity of the cyst may differentiate these from the mesenteric cyst by ultrasound. The contrast studies also may help differentiate the duplication from the pyloric stenosis if there is a clinical concern. Preoperative ERCP, endoscopic retrograde cholangiopancreatography, or PTC or MRCP should be performed to evaluate the involvement of the biliary and pancreatic ducts. So if there is still a debate, the pediatric surgeon not sure about this is a true pyloric duplication or it is duodenal duplication, or there is involvement of the pancreatic duct. So in this condition or in this situation, it is recommended to perform ERCP or MRCP to evaluate the involvement preoperatively and plan your operative plan very well. The treatment, the majority underwent simple surgical excision after opening the pyloric canal longitudinally and close it transversely. In case there is a risk of damage to the pancreatic or the bile duct, accessible alternative is to drain the cyst into the duodenum or raw limb of the upper small bowel. In these rare cases, if there is a concern that when you decide to perform removal of this duplication of the pylorus, you may injure the pancreatic or the bile duct, so you may perform some sort of internal drainage. Duodenal duplication, esophagus, thoracoabdominal, and gastric duplication, pyloric, duodenal duplication account for about 4 to 7% of the all duplication, can present with vomiting due to partial or complete duodenal obstruction, yes, hematemesis or perforation of the gastric mucosa present in 10 to 15% of the cases, intestinal obstruction or obstructions of the pilopancreatic duct causing jaundice or pancreatitis. Intestinal obstruction or jaundice, pancreatitis. Duplication usually posterior to the duodenum and usually cystic and not communicating with the lumen. Occasionally tubular variant are present. These frequently contain a risk of the gastric or pancreatic tissue. Investigation also by the plain radiograph if the duplication is of sufficient size may appear as a large opacity in the right side of the abdomen, displacing the bowel. Abdominal ultrasound may show the cystic lesion below the liver with a classic double-layered appearance or a muscular rim sign as a duplicated part, hyperechoic outer, hyperechoic inner, and hypoechoic muscular layer in between. So the ultrasound may show this cystic lesion below the liver with this specific diagnostic feature. The contrast studies may show the duodenum displaced up with a peak-like appearance due to compression of the lumen. Presence of the contrast within the cyst confirm communication between the lumen. CT or MRCP better to define the anatomy. As we see, this is the duplication, large, huge duplications. And this is the dye accumulated proximally in the stomach due to obstruction by the presence of this large duplication. The treatment due to the potential presence of the gastric mucosa in the duodenal duplication cyst, they should be excised, if possible, dissected and excised. Intraoperative cholangiography may help determine the relationship of the cyst to the bile and pancreatic ducts. Very important for the pediatric surgeon to be very cautious. As we said in the start, we need to remove the duplicated part to eliminate the patient's symptoms and prevent recurrence. However, pediatric surgeon should not be more aggressive than usual or than needed to avoid injury. And also the pediatric surgeon should ascertain whether this duplicated part attached to the vertebral column or spinal canal. There is a communication, there is neuroenteric cyst, attached to the biliary or the pancreatic ducts or not. So please investigate the child very well. If you need to perform ERCP preoperatively or need to perform MRCP, go and perform, diagnose, plan your operative trick, and perform the surgery. It may be simple excision or need internal drainage or need mucosal stripping and partial excision, not to leave the child with a significant morbidity. In case where the lesion is extensive or if complete excision may compromise the biliary system, the cystoduodenostomy may be performed. The cyst may also be partially excised, stripping all the mucosa and leaving that part of the cyst which is adherent to the duodenum or pancreas. Very important to put all the varieties of the work when you plan or decide to perform surgery in this delicate part. You need to remove the duplication. However, you don't injure the duodenum or the pancreatic ducts. Otherwise, you will make a catastrophe. You will lead to a significant morbidity of the child or the baby. So you can perform partial excision, mucosal stripping. It's okay, it's approved. However, performing the optimal procedure for each individual case. Recently, some authors report successful endoscopic resection of symptomatic duodenal duplication cyst. However, open or minimally invasive remain more common. So successful endoscopic resection is reported recently in the literature. Pancreatic duplication. Yes, this is among the rarest type of the gastrointestinal duplication, commonly present as abdominal pain that is recurrent and chronic. They can easily be mistaken for the pancreatic pseudocyst. What differentiates pancreatic duplication from other gastrointestinal tract duplication is that there is communication with the main or accessory pancreatic duct. Very essential to differentiate gastric, duodenal, pyloric from pancreatic duplication. There is a communication, usually communication with the main pancreatic duct or accessory pancreatic duct. The cysts are similar to the gastric duplication, gross and microscopically, but they may or may not have attachment to the stomach. Yes, they can be intrapancreatic duplication, extrapancreatic, may be combined with a duplicated pancreatic tissue along an apparent duct. So maybe intrapancreatic cyst, extrapancreatic cyst, may attach it to the stomach, may be duplicated pancreatic tissue with apparent duct. The location of the ductal communication can be anywhere in the pancreas. On exploration, there is often significant fibrosis from the chronic inflammation. Intraoperative frozen section evaluations will differentiate duplication cyst of the pancreas from a pseudocyst based on the cell wall cellularity. The cell wall cellularity will differentiate duplication cyst of the pancreas from the pseudocyst or pancreatic pseudocyst. Simple cyst resection is preferred, but the location may lead to more complex resection. So it's very important. Pancreatic duplication communicated usually with the main or accessory pancreatic duct, maybe intrapancreatic, extrapancreatic, maybe connected to the stomach. Pediatric surgeon should diagnose the case very well. Small bowel duplication, very common, about 47% of the reported duplication, mostly in the ileum and mostly cystic. However, tubular duplication also occurs. Very common small bowel duplication. Arise from the mesenteric side and share a common blood supply with the intestine. May share a common wall or entirely separable from the native intestine. Duplication of the ileum. Tubular duplication range from few millimeters to whole lengths of the small bowel. Communicate with the normal lumen of the intestine and contain gastric or ectopic mucosa. May lead to hemorrhage. Site of the communication between the cyst and the small bowel may be proximal, so the content of the intestine will accumulate in the cyst, so the duplication will reach huge size like this, huge duplication cyst of the ileum, huge size distended with content. Maybe distal communication, so the cyst will be collapsed. The communication may be at several points. So this is tubular duplication cyst. The clinically may present diagnosed prenatal or incidentally diagnosed and may manifest with a palpable mass in the child or newborn or infant. May cause gastrointestinal obstruction by the extraluminal compression or may present with intussusception. This duplication acts as a lead point for the start of the intussusception. May lead to segmental volvulus, which is sometimes seen in the neonate related to the duplication. Investigation, we usually start by the plain X-ray, which may show non-specific displacement of the bowel gases, may show signs of the bowel obstruction. Ultrasound is the initial imaging study. Differentiate the mesenteric and duplication cyst. Duplication cysts usually show hyperechoic, hypoechoic in between, double wall sign in these cysts in ultrasound. If the ultrasound operator are well experienced in performing these signs. A contrast study may demonstrate the displacement of the bowel displacement displaced by the cyst. CT scan less helpful than in other locations and may lead to unnecessary radiation exposures. Usually plain X-ray, ultrasound, contrast may diagnose small bowel duplication. The presence of the ectopic gastric mucosa is found in about 80% of the tubular duplication, 20% of the cystic duplication. So this meaning that the child may present with painless gastrointestinal bleeding. On technetium scanning, the small bowel duplication can be mistaken for the Meckel diverticulum. The treatment. Operative treatment will vary based on the type and the size. Yes. Small and cystic duplication could be enucleated or removed or excised, provided that the native blood supply can left intact. Small bowel resection with primary anastomosis is acceptable and preferred depending on the quality of the bowel and the length of resection. Small segment of the bowel, you can excise the bowel segment with the duplicated part, provided that small part, not affecting the continuity, not affecting the length of the bowel. Long tubular duplication, actually challenge for the pediatric surgeon. Resection of the large lens of the bowel increase a complication may lead to short bowel syndrome. In these cases, mucosal stripping through the multiple intrastomies. We perform multiple opening and remove the mucosa. Will preserve the bowel lens, decrease the risk of the ulceration or hemorrhage from the ectopic gastric mucosa. Laparoscopy increasingly being used for the diagnosis and treatment, minimizing open exploration, decrease hospital stay, long duplication related to the ileum appeared well in laparoscopic view. Colonic duplication will go down the colon. Rarest reported gastrointestinal duplication, double colon as we see. This is colon and colon, duplicated colon. About 13% of the gastrointestinal duplication, frequently diagnosed in infancy, and some reports suggest female predominance. Majority are on the mesenteric side of the bowel in the cecum and are cystic. Some authors propose the simple classification of the colonic duplication as a type 1, type 2, and type 3. Type 1 is mesenteric cyst, just cyst. Type 2 is the diverticulum. Type 3 is a tubular duplication, which is actually more common type. 1, 2, 3. Etiological factors for the development of the double colon, the most valid theory, suggests that there is a division of the hind gut into two parts at the stage with multi-organ developmental potential. This hind gut and a leg normally form the distal ileum, colon, rectum, bladder, urethra. Divisions at same initial stage could therefore be responsible for the duplication of the lower urinary tract. So they suggest that the correlation between duplicated colon and the anomalies of the urinary tract may lead to formations of the hind gut. And these divisions of the hind gut and the leg may be abnormal, may lead to abnormalities in the genitourinary tract. Tubular duplication of the colon is less frequent, vary in the length and the complexity. Long duplication have a higher frequency of associated anomalies, genitourinary, related to the hind gut development, supporting partial twinning theory of the embryogenesis. Presentation may be large bowel obstruction due to compression. Yes, mass effect. The double colon will compress the colon, original bowel, and obstruct. Intussusception may act as the lead point or volvulus. Gastrointestinal bleeding infrequent because colonic duplication rarely contains ectopic gastric mucosa. Complete colon duplication usually asymptomatic in neonatal period unless duplication of the anus or an abnormal orifice in the perineum is present. So usually complete duplication is asymptomatic unless there is abnormal opening. So the pediatric surgeon observe abnormal opening in the perineum, or there is duplicated anus. So the pediatric surgeon suspect duplicated colon. Duplicated colon may or may not communicate distally with the native colon and can have double anus. Yes, like imperforate anus, the tubular duplication may be blind intact or may fistulize to the perineum or other part of the gastrogenitourinary system. For diagnosis, plain X-ray may demonstrate cystic or diverticular type. CT typically confirm the diagnosis. The contrast, very important, will define the anatomy of the communications and will also define the anatomy with the communication of the genitourinary tract. The contrast enema will show double colon and the arrow point to the septum in between the two parts of the colon. This is one colon loop and this is the second duplicated colon diagnosed with a contrast study. So contrast will define the anatomy, show the communication, very essential for diagnosis. Associated genitourinary and lumbosacral spine abnormalities can also be demonstrated on appropriate radiological studies, particularly when dealing with type 3, which is a tubular. Isotope scan rarely of benefit in the clinic, as we said that it rarely contains ectopic mucosa. Duplicated colon rarely contain ectopic, so the need isotope scan is very limited. The treatment will vary depending on the type and the size and the associated anomalies. Very essential to start with this statement when you are asked about duplication. Will vary according to the type, the size, associated anomalies. Surgery for chronic duplication rarely indicated in the neonatal period unless there is a complication. There is obstruction or associated imperfections. Small cystic duplication, like that of the stomach, treated like small bowel and the stomach with enucleation or resection anastomosis. We resect this part containing the duplication. Mucosal stripping not routinely needed, as a chronic duplication rarely contain gastric mucosa. Very essential difference between the chronic and the small bowel and the gastric, the other duplication. Long tubular duplication, present treatment challenge for the pediatric surgeon. Resection and colectomy, considered aggressive by many surgeons to remove the whole colon. Long tubular duplication with a distal communication may be treated conservatively because the duplicated colon drain and communicate with the native colon and pass. No problem. We may need to give the child stool softener. Long tubular duplication with no distal communication. A communication must be established, and if a small communication is present, this opening needs to be enlarged to relieve the obstruction. So duplicated colon. If there is a distal communication, no problem. We can make stool softener or give a stool softener to the child. If there is no distal communication, we can perform a communication. Or if the communication is narrow, we can enlarge the communication, aiming to drain the content of the duplicated colon. As the duplicated colon don't contain ectopic mucosa, it's very important that we may not need to remove this part or strip off the mucosa. Total chronic duplications, a treatment aimed to end with the two colon draining through one anal orifice. If one part of the colon already reached the perineum and the other colon is divided anastomosed to it using linear stipular, we can put both limb of the linear stipular and anastomosing both colons together to form single colon, if one reaching the perineum. If neither colon reach the perineum, this is one colon and this is the second colon, don't reach the perineum, formal pull-through will be required. The neonatal management of any of these situations is to fashion defunctioning colostomy to achieve drainage of both colon. In the neonatal period, may need to perform colostomy draining both colon. So, if one colon reach the perineum and the second don't, we can use linear stipular to open both lumen together. If neither colon reaches the perineum, pull-through is performed. Neonatal management with a colostomy, you should consider to drain both colons, not only one. Fistulous tract to the perineum or other organ need to be excised and associated anomalies need to be addressed. Genitourinary tract anomaly, as this related embryological to the hindgut development. Finally, rectal duplication. About 3 to 5% of the gastrointestinal duplication, about 70 cases of the rectal duplication have now been reported in the literature. Most often found in the presacral space posterior to the rectum. More than 50% of these have been example of hindgut winning, double hindgut. As we see, this is the rectal duplication cyst. Rectal duplication cyst usually form in the retrorectal space. In the retrorectal space behind the rectum embryogenesis attributed to the pinching of diverticulum in the embryo, formation of the diverticulum and pinching off, in contrast to the caudal twinning which occur in the 10 millimeter embryo associated with complex hindgut anomalies. So cyst, isolated rectal duplication cyst, is considered as pinching off diverticulum, not caudal twinning, which reported to be associated with complex hindgut anomalies. The presentation, the rectal duplication may present with fistula or perineal mucosal swelling extending to the perineal area. Children typically present with constipation due to mass effect and pressure effect. Less frequently, the rectal duplication can be associated with anorectal malformation, fistulized to other pelvic organ, present in the adulthood with obstruction or bleeding, ulceration due to presence of gastric mucosa. Diagnosis: digital rectal examination may relieve mass or bulge in the rectum, in the anal canal. Multiple imaging modalities can aid in the diagnosis. CT, MRI contrast, as we see. This is native rectum and this is a duplicated rectum. Very apparent in the CT scan. Native rectum and duplicated rectum. The treatment is excision, transanal or transcoccygeal, depending on the anatomical variation. Division of the septum between the duplication and the native rectum or fenestration of the common wall may be an option. The posterior sagittal approach for longer and more extensive duplication will provide better exposure. As with other duplication, it's prime importance to remove all the mucosa. The muscularis can be lifted. Some patients may require initial colostomy for large or complicated duplication. The management of associated anomalies, presacral tumors, anorectal malformation may be difficult and often require preoperative evaluation of the both gastrointestinal and genitourinary tract. Continence is essential, and therefore the treatment strategies must be individualized based on the finding in each case. So associated anomalies, presacral tumors, anorectal should be considered and treated, and also continence is important element in rectal duplication. In conclusion, we can conclude that gastrointestinal tract duplication are a rare congenital anomaly that occur anywhere along the gastrointestinal tract, commonly in the small bowel. The mucosa is typically the same as the adjacent bowel, but can contain ectopic tissues. Gastric mucosa is the most common. Gastrointestinal tract duplication, diverse and complex group of anomalies. Presentation is highly variable and can occur with acute or chronic symptoms. They are discovered prenatal or incidentally diagnosed with large varieties of the symptoms. Foregut duplication typically have associated respiratory symptoms. Mid and hindgut can present with obstruction, perforation, nausea, emesis, or hemorrhage. These lesions usually cystic and tend to contain mucosa similar to the adjacent bowel. However, ectopic tissues, most commonly gastric mucosa. Surgical treatment will depend on the site and the type of the cyst. Small duplication in accessible areas like the small bowel may be excised with a portion of the adjacent normal bowel. Yes. In other locations where the resection would endanger the adjacent structures, simple anastomosis between the cyst and the normal intestine can be performed, provided that there is no gastric mucosa. Otherwise, mucosa need to be stripped off and removed. If bleeding has been persistent complaint, one can assume the presence of ectopic gastric mucosa. Very important. If resection is contraindicated, the lining mucosa may be stripped from the cyst, leaving the muscle wall in situ. Minimally invasive surgery, thoracoscopy, laparoscopy. At present, there are no controlled studies to determine if the outcome of using minimally invasive are superior when compared with the open surgical technique. This is in part limited by the rarity of the disorder, limited number of cases, and would require large multicentric studies. However, there is increasing number of the cases studies showing favorable result with minimally invasive approach. So it's very essential. Our subject today is very important. Gastrointestinal tract duplication. All pediatric surgeons must be aware about this disorder. This disorder can diagnose prenatal or can be diagnosed incidentally. This gastrointestinal duplication may present with acute or chronic symptoms, or may be asymptomatic. The duplication is a part, previously called diverticulum, or giant diverticula, or enteric cyst, or unusual Michels. William Sladd in 1937 described 3 criteria to diagnose alimentary tract duplication, intimately related to some part of the gastrointestinal tract. Well-developed smooth muscular coat contain mucosa same as the gastrointestinal tract. The gastrointestinal duplication are best described and studied anatomically, may be related to the foregut, mid-gut, hindgut. The diagnosis is very essential. The most important is the diagnostic features with ultrasound, double wall sign, and the presence of hyperechoic rim outside, hyperechoic rim inside, and hypoechoic rim in between. Very essential for the pediatric surgeon to understand this is cervical esophagus, thoracic esophagus, maybe duplication cyst, maybe thoracoabdominal, maybe gastric duplication, pyloric, duodenal, pancreatic, small bowel, large bowel, colon, or rectum. Usually the options related to the surgery is simple inoculation or excision if it is possible. If possible, you can perform primary resection and anastomosis to remove the part with the surrounding bowel, provided that the blood supply is intact. Very essential, don't forget that some cases associated with spinal or vertebral abnormalities or communication, neuroenteric cyst. Pediatric surgeon should diagnose this association, and that neurosurgeon should be available and ready to work with the pediatric surgeon in dealing with such complicated cases. I think this is an important topic in pediatric surgery and for the pediatric surgeon and the pediatrician. Child present with abdominal pain, abdominal mass, painless gastrointestinal bleeding, intestinal obstruction, intussusception, localized volvulus. All this presentation may be related to gastrointestinal duplication. The duplication may communicate with the spinal canal or the vertebra. The duplication may communicate with the biliary or the pancreatic duct. The pediatric surgeon needs to remove the complication, remove the ectopic mucosa, however, not to be more aggressive than needed, not to leave the child with significant morbidity. Thank you very much for watching this subject. I hope it will be very beneficial for all pediatric surgeons and pediatricians. Thank you. and see you later in next subject of pediatric surgery made easy. Thank you very much.